that will logically inform and facilitate the conversation you have with Dr. Conklin next Thursday, where she'll be doing a little bit of a review of the stuff that I talked with you about today, and then she'll get into pain measurement and how electrotherapeutic modalities are actually used for pain. Okay, so I can honestly say I don't think, I've been a practicing physical therapist now for over 35 years. I don't ever recall a patient coming to me with their only complaint of being a little bit of tingling or a little bit of numbness or a mild amount of weakness, right? Especially, and it's mostly because I do outpatient orthopedics for most of my career. Almost always, probably over 95% of the time, the reason that people are coming in to outpatient orthopedic settings is because of pain, right? That's what gets them in the door. That's what gets them to go see the doctor, to want to go see a physical therapist. It's the number one reason people seek medical care in general, and it's the number one reason why people seek outpatient physical therapy as well. Now, pain is obviously unpleasant. It's not something that's fun. That's why people like to try to get rid of it. But it often gets coupled with muscle spasm. And pain and muscle spasm can start to develop in kind of a vicious cycle, right? So the way that would work is, let's say you have some sort of injury or some sort of problem develops that results in pain. Well, when your body's in pain, there's a natural reflex for muscles to tighten up. It's like a way of your body attempting to protect itself, to sort of guard itself. So muscle spasm often will develop in people who are having pain as an automatic reflexive sort of response, okay? If your muscles are in spasm, that will restrict your movement or will change your movement patterns. If certain muscles are in spasm, you're not going to be moving in a normal way, right? That abnormal movement, coupled with some of the neurotransmitters and chemicals involved in the pain process, release various nociceptive substances, right? Cytokines, chemokines, neurotransmitters. And those different chemicals now within the tissue increase the pain. They facilitate the pain. They make the pain easier to provoke. They make the pain worse. And then if the pain is worsened by a result of the upregulation of all these chemicals, then the muscle spasm might get worse, okay? And if the muscle spasm then gets worse, then that's going to affect your movement even more, right? Creating even more abnormal movement or restricted movement, releasing more substances that are related to the facilitation of pain, right? So it's kind of this pain spasm cycle can be kind of vicious, right? And what you're going to learn with Dr. Conklin in Foundations 2 are some ways to interrupt that cycle, to stop that cycle. That's part of our job as a physical therapist, is to relieve the pain and decrease the muscle spasm so that we could then move forward with focusing on getting the strength back, getting the function back, restoring normal gait, a normal ability to do things. So pain comes in two varieties, acute and chronic, and we'll delineate those a little bit more specifically on slides that are coming up. But whatever kind of pain you have, it certainly, we've all been in it at some point along the way in our lives already. Even as children, we probably had pain for some reason along the way. And it can obviously affect our everyday activities, our recreational activities, our household chores. It could affect our ability to do our work, to concentrate on our work, or even physically perform our work. It can affect our mood. We might get depressed if we're in pain. We might become upset if we're in pain. And it can also affect our relationships with our family, with our friends, with our employers. And There are some interesting phenomenon in terms of related to gender and sex when it comes to pain. Women in general have a higher incidence of pain than men, although men certainly experience pain as well. And older adults have a higher incidence of pain than younger adults. And we'll talk about the reasons for that in a couple slides down the road here. Chronic pain affects about 30% of the population in the United States. A third of the population in the United States are living with chronic pain. Okay? Now, that's a problem, obviously, that's a big problem. What is another huge problem that has emerged over the past 10 to 15 years in the United States that sort of goes hand in hand with this high prevalence of chronic pain? Kristen? Painkillers, right. Using in particularly the 1990s and early 2000s, overprescription and overuse of opioid medication to relieve chronic pain. And what has that led to or contributed to in this country? An epidemic of opioid addiction, right? Okay, so again, we have some more slides to get into a little bit more detail about that as well. Coming up. There is the International Association for the Study of Pain. This is the professional organization for the study of pain. Like, this is like the go-to source. They've got a website. You can get all kinds of cool information, the latest breaking news on pain research. This is literally like the source, okay? And they've come up with a definition. The official definition of pain, better than Webster's dictionary, right? So the IASP definition is pain, an unpleasant sensory and emotional experience associated with either actual tissue damage or potential tissue damage, or described in terms of such damage. Okay? So, that's what the definition is. Now, Kathleen Sluka at the University of Iowa, she's a physical therapist, pain researcher, and she has said pain is a complex experience that is unique to each individual. And as such, the experience of pain is very difficult, very challenging to define and difficult to treat because there's so much individual variation across people. She also has noted that pain is often now considered like the fifth vital sign, right? When you are talking with your patients for the first time and meeting for the first time, yeah, you want to know their respiratory rate, their heart rate, their blood pressure, right? But, you know, generally we're going to be asking them about pain as well. And if they have pain, we want to get some additional information about that. Okay. Acute pain is the pain you feel immediately after some injury or trauma, associated with discrete tissue damage, all right, or potential damage to tissue. You kind of know when it happened, right? The day that the hatchet landed on your skull. It's related to pathology or injury, a well-defined time of onset, and it serves to protect you from further damage and allow for healing. So an example of that is, let's say you are out camping and you're in your bare feet at the campground and you accidentally step into the campfire, right, onto the hot embers. You're going to feel that acute pain in less than a second. It's going to get to your brain, okay? And what are you going to do? You're going to immediately pull your foot out. So that's the purpose of that pain. It's to let you know as quickly as possible, something terrible is happening right now. Get out, right? Save yourself, move away, step out of the fire, okay? And the way that happens is that in our tissues of our body, including skin, but also muscles, joints, viscera, the meninges, and even in nerves themselves, there are nerve endings. So even our nerves have nerve endings in them that can transmit pain and see pain. Those types of nerve endings are called nociceptors. Now, and essentially, it's the nerve, the very specific type of nerve ending, and stimulation of that will trigger or begin this pain transmission process. They can be stimulated by thermal factors, like if something's too hot, burning hot, pain, right? Something too cold, like ice cold. You plunge your hand into freezing cold water, within seconds you'll feel pain. It won't just feel cold, it will feel painful, okay? Mechanical and chemical stimulation can also trigger these nociceptors. They release various neurotransmitters and neuropeptides, such as substance P. Those are the things that help get the signal to move up the system. And then there are various, in this process of nociception, there are other cytokines and chemokines involved with inflammation that after any injury, almost immediately the inflammatory process starts to get jump-started. And in that inflammatory process now, various cells in your body are releasing things like histamine and other chemokines and cytokines that can all make pain worse. They can further activate these nociceptors, or they can facilitate these nociceptors, right? And that's, so picture this, if you've ever had an injury where right after it happened, you felt maybe some instant pain, that very, very acute pain. But then over the subsequent hours, you started to feel more pain or worse pain over the next day, kind of building up. That's because some of that pain was the acute pain, the immediate nociception, like danger, get out. But then what's happening, if there was tissue damage or trauma, now there's inflammation. So these circulating chemicals are starting to cause more pain because they're continuing to facilitate the activation of the nociceptors and continuing to send that signal up to the brain. So once the nerve ending is actually stimulated or triggered by heat or cold or some chemical irritation, like an inflammatory chemokine or cytokine, or by a mechanical stress, then it's going to travel up the nerve fiber to get to the spinal cord, right? So the nerve ending is the very end of the nerve, and then the nerve fiber en route to the spinal cord. And we have, for carrying pain, the two big types are A delta and C fibers, all right? Now the A delta, they carry pain impulses a little bit faster, so they carry relatively rapid, sharp pain, such as pulling your foot out of the fire when you step in the fire. Okay. Now, the other kind of fibers you have for pain are C fibers. They're unmyelinated and they're smaller in diameter. What does that mean? The signal moves along them more slowly, right? If you have a nerve fiber and if it's myelinated and it's bigger diameter, it's like the train will shoot through that tunnel faster, right? The signal moves more quickly. So A delta, it carries pain more quickly than the C fibers, which are slower. Okay. However, you also have another kind of fiber in your peripheral nerves called A beta, and those are not related to pain. Your A beta are related to your light touch sensation, right? And they're even faster than the A delta, right? Now, for right now, you just kind of have to keep that in mind. But your other nerve fibers, not associated with pain, but just associated with things like light touch, they're even faster than the A delta pain fibers, okay? And the reason you need to know that is going to become clearer once we start talking about the gate theory of pain control. And when pain is transmitted through A delta or C fibers, the characteristics of pain are a little bit different. because these A delta fibers carry the messages so quickly, pain is also, it's often like sharp, abrupt, sudden, perceived as kind of urgent, right? Whereas the C fibers, they're transmitting the impulses more slowly. The type of pain that's usually attributed to transmission along C fibers is more of that like dull, achy, throbbing pain that is maybe a little bit more diffuse or less specific to one area, less well localized. Okay. So, how does it get to your brain? This will show you how. This is the spinothalamic tract. This is the main central nervous system pathway. There are some others that we'll introduce briefly, but this is number one, numero uno. You step in the fire, okay? Thermal irritation of nociceptors, okay? That is going to travel to your spinal cord along the first order afferent neuron, okay? Where does it go? It goes into the dorsal horn of the spinal cord on the ipsilateral side. But then what's going to happen is it's going to cross over to the contralateral side, and there are interneurons here, and it will actually synapse on the second order neuron, right? And then that second order neuron will go up the spinal cord, eventually making its way to the brain. And that's why you feel and perceive pain. So that's really the basic pathway. It starts with the transduction of pain, the stimulus to the nociceptors, transmitted to the spinal cord via the first order afferent neurons. Pain might become modulated in the spinal cord because remember at that level where it synapses from the first order neuron to the second order neuron, there are other interneurons in there too. And they can modulate pain. And it could go in either direction, depending on how those interneurons are being activated and what they're doing. They could make pain worse, they could dampen pain. So these modulatory interneurons in the spinal cord can have an effect on either dampening pain or making pain seem even worse, depending on what's going on with them. And then eventually up to the brain, where you perceive it. Yeah.
Question.
Go ahead.
So when it comes to the fibers, I just had a quick question. Is it like a one or the other type? There's going to be a mixture in terms of like the...
Whether it's A, delta, or C? No, it's usually going to be both at the same time.
Okay.
It's not really solid, because they're in the same peripheral nerve, and the nociceptors can affect either kind of fiber or are associated with both kinds of fibers. So they'll both be active at the same time. Yep. Okay. So this is the spinothalamic tract, but then the other tracts that are also associated with pain are the spinomesencephalic tract. And that, instead of going to your cortex, that terminates in the periaqueductal gray region of your brain. And that's involved with descending modulation of pain. So in other words, your brain, once the pain signal gets to your brain can then start to do things to modulate the pain, right? To change your perception of it. And that goes on in the spinomesencephalic tract. In the spinoreticcular tract, okay, that is involved with the emotional aspects of pain, and it can also modulate pain. So when the signal goes to your brain through the spinoreticcular tract, it could be involved with either facilitating or inhibiting the pain, and also your emotional responses. The connections in the brain related to pain are partly understood, but also an area of unending research. And the more we learn about it, in some ways, the less clear it becomes. We're learning how different parts of the brain are connected and related to the perception and the processing and the modulation of pain. This is another chart that sort of shows the spinothalamic pathway with just a different view. What we have here, sketched out a little differently. We have some A delta fibers, they're lime green. We have some C fibers. Okay. So a nociceptive input will trigger pain transmission along these fibers. They're going to move faster on the A deltas. They're going to get to the train station a little bit more quickly, right? Once they get to the dorsal horn, that's where they synapse on a second order neuron. Then they're going to cross over to the other side, and they will go eventually up to the cortex. Remember the spinothalamic pathway? But there are also branches that go off to the periaqueductal gray, into the reticular formation, and those are those other two pathways that we talked about on the prior slide. So some of that information gets detoured over to other parts of your brain en route to cortex. Also, the one thing I think that's kind of important that's not in this diagram is that in here, in the spinal cord, it's a little bit more complicated than just first order neuron synapse on second order neuron. There are also interneurons in here, other neurons that can affect what's going on with the signal being transmitted by these neurons that are in the diagram, okay? And that's, when we talk about pain modulation, that's what we're talking about. Okay, so again, pain modulation. Ascending modulation means the pain signal is modulated on the way up, right? So right here in the spinal cord, the pain hasn't even gotten to the brain yet, and it can already be modulated, either dampened or facilitated by what's going on here in the spinal cord. Okay? That's an ascending modulation before it even got to the brain. But then there's also descending modulation, right? Things that can happen from the brain down. So for example, distracting thoughts, right? Mindfulness meditation as a treatment now used for management of chronic pain, okay? Mindfulness meditation isn't technically a distracting thought, but it's using the power of your brain to change what you're thinking about, what you're focusing on, and how it's affecting you, okay? Descending facilitators of pain are also related. The descending modulation can make pain actually better, or it can make pain worse, right? Sometimes, depending on what's going on in your brain, it might make the pain seem more widespread or more intense. That's kind of part of how referred pain happens. And referred pain is when you feel pain in an area other than exactly where the injury is, okay? So for example, if you have a heart attack, a myocardial infarct, well, you might have chest pain, right? But you might have neck pain, you might have pain in your left arm, okay? And that's all referred pain. It's visceral referred pain. And it's happening due to central nervous system modulation, right? Secondary hyperalgesia, that means that through this descending facilitation of pain, you might become more easily irritable, or the pain might be more easily provoked. You're more sort of sensitized, or your perception of the pain is heightened or more easily triggered. And then another very interesting thing that you very rarely see, but I think it's also sort of fascinating, is contralateral hyperalgesia, or mirror image pain. That means the injury is in your left arm, right? But you start to feel pain in your right arm where there's nothing wrong. How could that possibly happen? Is that person crazy? No, there's just some things that have been going on in the central nervous system modulation of their pain that has created a little signal confusion, and now they're feeling the symptoms on their other limb. All right. So this modulation of pain is very much influenced by the chemical neurotransmitters along the pain pathways, as well as over time in chronic pain, it's not just neurotransmitters, but can actually be neuroplasticity of the brain itself, the actual neurons in the brain and the relative sort of mapping of the somatosensory cortex can actually change over months or years in an individual with chronic pain. So some of these pain modulating central nervous system things some of them are related to the circulating chemicals and neurotransmitters, but over time, some of them become hardwired, right? It's like part of like the hard drive and the soft drive, or the hard drive and the software. If you think of the neurotransmitters and the chemicals, maybe as sort of a temporary sort of software, but the brain itself being the hardware. Okay, this is the gate theory of pain modulation. And this is why earlier I mentioned to you the A beta fibers. The A beta fibers are your light touch fibers in your skin, all right? And it's those that we take advantage of when we use an electrotherapeutic modality like TENS, transcutaneous electrical nerve stimulation. What TENS does is it stimulates the A beta fibers, okay? The most obvious example of this is if you accidentally slam your elbow into the wall and it hurts. What's the first thing you're going to do instinctually, most of the time? Right? You start rubbing it, right? It's almost like a reflex. Somehow your body knows if you rub it, it's going to help a little bit. The pain it's going to help manage the pain, that acute pain. Why is that? Well, why is that happening? Well, when you rub your skin, you're stimulating the A beta fibers, the light touch fibers in the skin. And remember that those are even bigger and more myelinated than the A delta pain fibers. The light touch fibers, the A beta, transmit even faster. So, normally what happens is, if you have pain, it goes, from the primary afferent, it's going to synapse in the dorsal horn on the secondary afferent. Somewhere in that process, there's probably an interneuron, right? Remember I said in the spinal cord there are also interneurons that can modulate pain, right? But sort of straightforward pain happens this way. From nociceptor, primary afferent, synapse on the secondary afferent, and then on its way up to the brain it goes. But if you then put on a TENS machine, or you start rubbing your elbow, what are you doing? You're stimulating the A beta fibers. They are bigger diameter, they are more heavily myelinated. What they do though is they go to the same dorsal horn region of your spinal cord and they provide input to an inhibitory interneuron. And the additional activation or stimulation of that inhibitory interneuron starts to block some of the transmission of the pain, okay? So you're sort of using this rapid transmission of light touch sensation to essentially kind of throw a block now at the dorsal horn level of the spinal cord so that the pain impulses won't be able to get through. They're at the spinal cord level, they're being inhibited by the fact that the A beta stimulated an inhibitory interneuron. All right? So that is how the gate theory of pain works. And that's really one of the biggest theories of why TENS works, right? This is probably a good part of what's happening when you put on a TENS unit or when you rub your elbow. Now, there could be other reasons why TENS units are working as well. It could be placebo effect, partially. It could be patient expectations of benefit, right? There might be some other mechanisms of why TENS works, but gate theory is certainly one of them. Okay. So, people experience pain and perceive pain in different ways. There's a lot of individual variability. Why is that? Well, there are a number of reasons. There's no single reason why. So it has to do with their mood and their cognition and how they're thinking about pain. Some people, if they're in pain, they're gonna do anything they can do to tune it out, right? They'll watch TV, they'll listen to music, maybe they'll do some exercise, they'll do meditation. Whereas other people, it's just sort of their nature and their personality, they experience pain, they don't want to move. They're afraid the pain's going to get worse, right? They have a fear of pain. They develop maybe a fear of movement. And it might make them anxious. It might make them depressed. They're worried about, what does that pain mean? Am I going to die, right? So beliefs about pain, fear of pain, the person's a level of anxiety or apprehension related to pain or injury. Cultural and social factors are also related to the perception of pain. It's across cultures, it's even within cultures, different family dynamics, right? Some families, some groups of people who are around other people like them, maybe are very emotionally expressive. Whatever it is, they're gonna let it out and they're gonna talk about it, right? Where then some other family or people from some other culture might be much more rigid and stoic. No, we don't talk about our feelings, thank you very much. And if we're in pain, we're never going to admit it, okay? So you sort of see that across cultures, across families. Fatigue and being tired or worn down can be a factor related to feeling a greater perception of pain. There could be changes in pain thresholds, how easily pain is triggered. In other words, the pain threshold is how much heat or how much pressure do you have to put on that nociceptor, right, before it causes pain. So as an example of that, if you take your thumb and put your thumb in your web space, your Hoku point, and start pressing very lightly. Okay, well you feel it, but it's not painful. You're probably you're putting some pressure on your nociceptors, but not so much that they're starting to transmit any pain. Now keep pushing harder and harder and harder, as hard as you possibly can, and at some point, you're now stimulating your nociceptors. But that threshold can be modifiable. It can change based on your fatigue, your nutrition level, your mood, right? Various things can move that threshold. So if you did the same activity next week, you might have to push a little harder, or maybe not push quite as much for you to feel the pain. Autonomic nervous system responses, your sympathetic nervous system is related to the perception of pain. Genetics, and we'll talk about that in a little bit more detail. Demographics such as gender and age. Okay. This is just sort of everything we just talked about, putting it into sort of a chart where pain is in the middle, and then an individual person's experience of pain is informed not only by the nociception, but also psychological factors, affective factors like their mood, their family and social life, their job, their attitudes and beliefs about pain and injury, behavioral issues like communication, medications that they're using, whether they're getting enough sleep or not. Sleep is very restorative. And if you're chronically not getting enough of it, your pain thresholds might be lower, right? You might be more vulnerable to experiencing pain. And cognition. So all these things kind of going into inform an individual's experience of pain. Now, let's talk about sex and gender. In some common and recurrent pain conditions, such as headache and back pain, women do have reports of higher intensity than men and longer duration and more frequent pain, generally, than men. However, it's just not that simple, because there's some conflicting evidence on this, right? So in some studies of acute low back pain, men reported higher pain ratings than women for a comparable episode of acute low back pain. So, you know, it's a little hard to make these sweeping, global, overgeneralized statements here about gender. It's somewhat complicated. But we do know that the prevalence of certain musculoskeletal conditions that are painful are higher in women. So it is true that women more than men have diagnoses of fibromyalgia or TMJ dysfunction or carpal tunnel syndrome, and osteoarthritis maybe. I'd say that one you could put a little question mark by. Okay. So why is that? Why might there be some differences due to sex or gender when it comes to pain? Well, one is, again, could be differences in the underlying pathology, like the prevalence of fibromyalgia diagnoses, right? The way that women's hormones affect the inflammatory or disease process are different than men's. Right? We have different levels of circulating hormones. And in women, those levels of circulating hormones will vary monthly over the course of the month, whereas in men, they're a little bit more flatline and steady. There are differences in pain signal processing between men and women. Women show a higher rate of temporal summation, and that's a central nervous system thing that we'll talk about in more detail coming up on another slide. I'll tell you exactly what that is. Biases maybe in reporting pain or healthcare utilization. Maybe there really aren't such big differences between women and men, but women just report it more. They're more comfortable talking about it. So we hear about it more from them than we do from men, and then it makes us think that, oh, well, women have more pain than men. Well, maybe not so much. Maybe some of it's related to that. And social behaviors related to gender roles and stereotypes. In some cultures or in some families, men may be expected to be more stoic and less emotional. Okay? Things like anxiety, worry, being overly emotional or negative can certainly have an influence on pain. And then there's also this term called pain catastrophizing. And there's actually a tool, an instrument you could give someone, a questionnaire, called the Pain Catastrophizing Scale. And it's a one-page questionnaire. Someone answers all these questions, you score it, and it gives you, the therapist, a sense of, is this patient like a real catastrophizer, or are they lower on, where are they on that spectrum, right? In other words, the extremes of pain catastrophizing would be a score of no pain catastrophizing, the person's happy-go-lucky, they're in pain, they don't care, they're still happy, life goes on. The other person, the extreme end of pain catastrophizing, any little pain, any little injury, they feel like maybe I should go to the emergency room, I'm probably gonna die, everything's over, right? That's the other extreme. But there are people in the middle. Most people are somewhere in the middle, okay? But there's actually a tool you can use to measure that. Okay, genetics and heritability. So there are certain genes, and these genes are expressed differently in different individuals that affect the processing parts of the pain system. So some of this processing of pain might not just be about our mood, our family, our culture, or gender, but also genetically determined. There are certain genes noted, such as COMT and TRVP1 and OPRM1, that are related to receptors, the regulation of stress hormones and neurotransmitters and chemokines and cytokines associated with pain. So different people are going to have different levels of activation of neurotransmitters, different responsiveness of receptors, some of which is just genetically determined, okay? There is a genetic predisposition to certain kinds of pain syndromes, such as migraines and back pain, right? It is seen that obviously there are exceptions to this, and there's not really a strong hereditary component to back pain or to migraines. But nonetheless, if you think about it, like, you probably can think of some families where like almost everybody in that family seems like they have back pain. Or like, oh my God, it seems like migraines run in that family. Well, guess what? Migraines might kind of run in that family. There is probably a genetic component to it. And of course, nothing is ever completely determined by either genetics or environment, but it's the complex interactions between the two that will inform the individual's response. So let's look at what happens when people get old. Well, the pain threshold is elevated. So that means that if the threshold is elevated, you have to push harder before you feel the pain. Like a lower threshold means it's easier to feel the pain. A higher threshold means that, okay, if I push in with my thumb here and I'm 85 years old, I actually might have to push a whole lot harder than I did when I was 20 years old to feel that pain. But it's kind of messy because concurrently with the pain threshold being elevated, there is greater pain sensitivity overall. There is greater central sensitization to pain in the central nervous system. There is less ability to endogenously inhibit your pain with circulating chemicals like endorphins and enkephalins that can help modulate and dampen pain. And when you're old, you don't produce those as easily. So if we put all of that together, what happens with older adults is they are more likely to have chronic pain than younger adults because of these, kind of the complexity of these physiologic issues, coupled with the fact that the older you get, the more likely you're going to have injuries or problems or comorbidities, right? So things, the longer you live, the more history you have, the more injuries, diseases, degenerative conditions, emerging psychosocial issues, loneliness and isolation is much more prevalent in older adults than younger adults. And that's related to depression, and depression is related to pain perception. Okay. Let's take a break. See you at 10. That normally wouldn't cause pain, right? But if you have a condition known as tic douloureux or trigeminal nerve neuralgia, that cold breeze hitting your face might cause sudden pain, okay? Sudden bolts of pain in your face. Or if you just rub your face, normally rubbing shouldn't cause any pain, right? Allodynia is when a relatively normal stimulus, routine stimulus that normally doesn't cause pain, actually provokes pain. Sensitization is this idea of heightened responsiveness. Okay, pain is more easily provoked. It's harder to get rid of. And there are two different types of that we'll get into those in more detail: peripheral sensitization and central sensitization. The peripheral sensitization occurs in the peripheral nerves, and the central sensitization occurs in the central nervous system. But in either case, in either place, those nerves can have a heightened sensitivity, more likely to transmit pain, to feel pain, to experience pain up in the brain as a result of these sensitized phenomena. Analgesia is just absence of pain, right? And that's why certain pain medications are referred to as analgesics, right? What's the goal of them? To make the pain go away. Go ahead.
I just had a question with the other types of pain. What would RSD fall under?
Well, so that is actually on Dr. Conklin's slide deck for next Thursday. She'll mention RSD briefly. So that is a nerve-mediated type of pain initially related to the sympathetic nervous system. RSD means reflex sympathetic dystrophy, and all of your peripheral nerves have sympathetic fibers. But those sympathetic fibers can sometimes become dysregulated and provoke pain in the periphery and the extremities. It can be very debilitating and very chronic. So it's a certain type of, well, originally, I guess you would call it a neuropathic type of pain because it's sympathetic nerve fibers that are the original driver of it. Okay. Hypoalgesia is the opposite of hyperalgesia. Hypo is the absence of pain into a stimulation that would normally be painful. Okay? So in other words, if I came over to the cinder block wall and I like beat my head against the wall 10 times, that would normally be painful, right? But if I did that and had no pain, something's wrong with me. Okay, that would be hypoalgesia. Anesthesia is the complete loss of all sensation, not just pain. Anesthesia is when you're completely numb. Like when you get an injection of Novocaine and when you go to the dentist. You have some temporary anesthesia in that region of your mouth. Pain tolerance is the greatest level of pain that the subject can recognize. And referred pain is when you feel pain somewhere outside of where the actual injury is. It gets referred to a different area. Paresthesia is the sensation of pins and needles. If your leg ever, quote, fell asleep, right? If you were sitting on your wallet or sitting with your legs crossed, and then when you stood up, you felt that rush of pins and needles or tingling sensations. Dysesthesia is abnormal sensations from the skin, like just funny feelings that you wouldn't normally have, like sensations that you're being cut, or someone's prickling sensation of your skin, or a burning sensation of your skin. Neuralgia is pain that is pain along a nerve distribution. So if the path of the pain is following some nerve, it might be called neuralgia. And then cephalgia is basically a nice clinical fancy way of saying a headache, which is something you're probably starting to develop right now as a result of all these slides about pain. So why does pain sometimes stick around? Why does pain sometimes become chronic, right? Well, it might be related to all of those things that we were talking about before, emotional responses and influences. There is also the fact that some individuals get secondary gain as a result of having pain. What's an example of that? Or what am I talking about when I say secondary gain as a result of having pain? In other words, like kind of a benefit.
Attention.
Say again?
Attention.
Attention, right. More people are listening to them, paying attention to them. They like oh, you're in pain, can I buy you a cup of coffee or a beer? Right, so it could be that. It could be attention, it could be affection. It could also be money, right? If you're in a lawsuit, motor vehicle accident, workers' compensation lawsuit, the more pain and suffering that you have documented in your medical chart, the bigger settlement you might get, right? So that's a secondary financial gain, a monetary gain, but a lot of times the secondary gains can also be emotional. And then of course, peripheral sensitization and central sensitization, those terms have already come up, but I just want to talk about them in a little bit more detail. So what is peripheral sensitization? This slide gives you richer information about that. This is the peripheral nerves have increased responsiveness and reduced threshold to nociceptors being activated by a stimulation, right? It's easier to trigger the pain. Why is that? Well, one reason is that after you have an injury, there's going to be inflammation. And there's this great term called inflammatory soup. That means all the cells, all the chemokines, all the cytokines, the histamines, the things that are going on in the vicinity can cause sensitization of the nerve endings. they irritate the nociceptors. Pro-inflammatory cytokines and chemokines like bradykinin and IL-1 beta, IL-6, TNF alpha, and histamine. All of those things can affect the sensitization of those nociceptors of peripheral nerve endings. The nociceptors themselves release neurotransmitters like substance P, calcitonin, and gene-related peptide. If they keep getting stimulated to continue releasing those neurotransmitters and nothing is done to stop that, then the pain might keep propagating. Glutamate is a very interesting excitatory neurotransmitter in primary afferent fibers and in inflamed tissues, and it is associated with hyperalgesia and sensitization of the primary afferent fibers. So a lot of this you can sort of see, it's almost kind of like a vicious cycle. If you have pain, injury, inflammation, then there's the release of all these chemicals and neurotransmitters that kind of make it easier for the pain to be transmitted and subsequently perceived. Okay. Plasma extravasation, and I have to admit, I don't even remember what that is. I wrote this slide last year, so I'm going to have to actually look that up myself and explain it to you next week. And I didn't notice when I was doing it. I did update them, you'll be happy to know, yesterday, but I actually didn't notice that bullet when I was updating them, and suddenly I can't remember what it is. Okay, migrating leukocytes and macrophages. When you have inflammation, generally cells go to the area too, like your body knows, we better send some cells to help with tissue repair, so leukocytes, macrophages going to the area, and they can also release some of these chemicals. So that's in the periphery. That's basically where it happened, okay? But now we go to the central nervous system, spinal cord and brain. Central sensitization is increased responsiveness to the nociceptive neurons in the central nervous system, where they're more easily provoked, they're more easily going to perceive pain, referred pain, secondary hyperalgesia. Those things all reflect central nervous system changes, as does temporal summation that we'll talk about on the next slide. So again, and as we mentioned earlier, some of central sensitization is occurring because of, on a neurotransmitter level, on a chemical level, but over many months or years, some of it can actually become hardwired in the relationship of the brain neurons themselves. Your brain, it has the capability of plasticity. That's why after a stroke, right, initially there's a lot of damage, there may be a lot of damage, but eventually people might be able to learn how to function or walk again, right, because they can start recruiting other parts of their brain. There's some amount of plasticity in the central nervous system, and that is also relevant here in the context of chronic pain and central sensitization. This is what temporal summation is, because we've now alluded to it on a couple different slides. Temporal summation is a central nervous system phenomenon, and what the red cylinder here is the painful stimulus. Okay, whatever it is, heat, or mechanical, right? The exact same thing. It's just repeated. It's not getting worse or changing. But the person's perception, the first time it happens, oh, that hurt. The second time it happens, oh, that hurt, but it hurts a little more now. And then the next time, it's hurting even more now. Like the stimulus isn't changing, right? It's just getting repeated. But it's temporally, meaning over time, that's temporal, summation, where that pain, because some of it is it hasn't completely disappeared from the first stimulus, then when the second stimulus starts, it gets a little bit of a jump start. And then before that second stimulus completely goes away, you get the stimulation again, and now that pain is gets another head start or a jump start. So that's what temporal summation is. Okay, chronic pain, unlike acute pain, which chronic pain just does really not serve a biological purpose. Now we said acute pain serves a biological purpose. You step in the fire, acute pain tells you to pull your foot out of the fire, okay? Chronic pain is really, doesn't have that protective effect. The definition is pain that lasts more than 3 months. It's still around, but it's really no serving any purpose other than making you miserable. It outlasts normal tissue healing time, so maybe even after the tissues have healed, you still have the pain. The pain is still there, it hasn't gone away. It may be greater than expected, given the person's physical exam. So let's say, even if there is still some damage or some degeneration or still some pathology, the amount of pain the person's feeling seems very out of proportion to that, okay? It might be greater than what you'd normally expect. It may also occur in the complete absence of any identifiable tissue damage, right? You examine the patient, physically examine them, and you don't see anything wrong, right? But they still might be experiencing chronic pain. It's usually not attributable to a specific pathology or the pathology happened at some time in the past. And it often does not really correlate or make sense with your imaging findings or diagnostic imaging findings or your physical examination findings. It is associated with why is it happening, right? Just like this is a little repetition and review now. It's associated with these neuroplastic transformations. The fact that in someone who has chronic pain, they are probably on a physiology level, there is probably both peripheral sensitization going on and central sensitization in both the spinal cord and the brain. Okay. So, when someone is experiencing chronic pain, right, that's no fun. It makes people miserable sometimes. It's not something you would choose to have. But there are other issues with it that come along with it. The baggage of chronic pain, the stigma associated with being chronic pain. Oh, you're afraid people are going to think that you're crazy or that you're just a complainer, right? That it's all, right? You ever heard all in your head, right? So people feel marginalized by that. People experience chronic pain. It is a real thing. You know, it's not imaginary. It's not something they can decide to shut off. Oh, it's all in my head. Okay, so now I'm going to suddenly wake up tomorrow and I'm going to choose to not have it. It's much more complicated than that. But there is stigma associated with it. There is provider bias. Some physical therapists, like some physicians, they don't really want to hear about their patients' chronic pain. They get burnt out working with patients that have chronic pain because chronic pain is hard to treat, okay? And because chronic pain is hard to treat, and people might resort to using non-prescription means to manage their chronic pain. Or they might start to abuse what their prescription pain medication is. So substance use disorders can develop in some individuals, not in all, but chronic pain is one of the drivers of substance use disorders. And hurdles to clear when we're sort of looking at chronic pain in the context of clinical practice. Unfortunately, some physical therapists and some physicians just don't know enough about it. They really don't understand it, so they don't know how to treat it. They don't know how to talk to patients about it. There are also access issues. If there's nothing wrong on your MRI, the insurance company is going to say, well, I'm not going to pay for any more therapy for you. Your MRI was negative. Your doctor said you're fine. So this chronic pain is all in your head. So, we're not paying for anything else. So there could be regulatory barriers, insurance coverage barriers. And another issue is that we're sort of really faced with now more than ever is identifying effective non-pharmaceutical interventions. So this is a chart that takes the phenomenon of pain and translates it into function and movement. Pain changes how we move. So top rectangle is pain plus your perception of pain plus your pain beliefs. All of that is going to result in changes in motor behavior, right? Maybe in a subtle way, if you have one muscle that's in spasm, for example, it might redistribute the muscle activity to other muscles, or it might change your posture. There might be subtle changes on a joint level, in the region of a specific joint, or muscles that are in spasm. More globally, though, you might be avoiding movement. Oh, I think that's going to hurt, I'm not going to do it, okay? So you stop walking, you stop bending, you stop lifting your arm up over your head, right? You avoid it. Now, when there are those changes in motor behavior, then there are going to be changes in motor output and mechanical behaviors. So within the tissue level now, right, kind of going back to kinesiology and biomechanics, there might be changes in the stiffness of the tissue, right? Stress strain graph, Young's modulus. There might be force generation issues. The muscle now, if it's constant spasm, it can't create normal force. There might be problems with the direction of the force if the muscle is in spasm or if the joint is out of alignment. There's going to be load distribution variability, and just the machine is no longer functioning properly, all right? Now, in the short term, that might be okay for a short period of time because you might need a little bit of that for a while to protect yourself, okay? In other words, if I have a broken bone in my foot, it might not be a bad idea for me to not, I mean, it might be a good idea for me to avoid running, okay, on it. If I just completely rip my rotator cuff apart, it's probably a good idea for me to not do military press at the gym tonight. So some of that can be protective, but there are potential long-term consequences. And that is that over time, it can alter your movement strategies, your relationship with the external forces of the world. It can create ineffective or inefficient movement patterns that put abnormal stresses on other tissues or other joints, and then maybe they start to hurt, or you develop secondary pathologies because of all the abnormal ways that you're doing things. And it can also lead to just suboptimal tissue loading. Remember, Wolff's Law from yesterday is our tissues in our body respond to the external forces. And that could be in a good way or a bad way. So if we have good, normal, healthy forces, then our bones are healthy and strong, our muscles are flexible and strong. On the other hand, we could also develop things like bone spurs, tightness, stiffness where we don't want it, okay? So lots of this sort of path to, from just having pain, now all the way at the very bottom, how having this pain for months or years has completely now changed our lives and how we move and what's tight and what's loose and how strong we are, and what kind of job we can have and what sort of work we can do. So the treatment models for pain are basically the traditional biomedical model, which you still go to. A lot of people in this country still go to this. Whatever's wrong with me, I'm going to go to the doctor and I want a pill. And I'm going to take that pill and then I'm going to be better. Okay? And that is, when it comes to, now for certain things, that's true, right? So for example, if you have syphilis, then you really do need to go to your doctor and you really do need to take penicillin, and then the penicillin will make the syphilis go away, okay? So there are times when the biomedical model works just fine. But for pain management, not really so great, okay? And first of all, it assumes that pain just has a very single, distinct physiologic cause. and that if I just give a pill, it can make it go away. And it's maybe you can, the theory then is, well, if we treat this problem, the pain should go away. And sometimes it maybe does. Like if you have an uncomplicated ankle sprain, right? You know what? You take a couple Aleve, right? And you take Aleve or Motrin for a couple days, and sure enough, you know, the pain went away. There are times in even with uncomplicated musculoskeletal problems where the biomedical model might work. If you just need a simple analgesic or an anti-inflammatory medication, and it's an uncomplicated problem. But remember, especially when we're talking about chronic pain, things are more complicated. And therefore, we need a whole different approach. The biopsychosocial approach considers the interaction of biological, psychological, and sociocultural influences. It takes into account the suffering and the emotional distress and the person's pain behaviors, right? How they're interacting and moving with the world, and whether they're fearful, whether they're avoiding things or not. Okay? So the biomedical model, taking pills, does not work well in patients with chronic pain. Okay? And another thing that we now know more than ever, what doesn't work well for the management of chronic pain? Opioid painkillers. They have been shown to be non-efficacious for chronic pain. Now, people in chronic pain, if they've been prescribed opioids for years, they're taking them still, maybe they're addicted to them, and lots of times they just don't see the irony, right? That if it was going to work, if these were going to work, they would have worked by now. You still have chronic pain, and you need more opioids. The doctor just had to give you a stronger prescription, right? Like it's sort of not, it's clearly not working. People develop tolerance over time. If you're taking a certain number of milligrams of morphine, a couple months later, you might need more to get the same effect. And the side effects go on and on. Dependency, addiction, overdose, paradoxical hyperalgesia, which is kind of rare, but some people, after a certain number of years or months on opioids, they actually have worse pain, right? Instead of pain relief from taking opioids. Yet they're addicted to them, so they keep taking them, but they're having paradoxical hyperalgesia. Of course, the synergistic effects with alcohol and other drug-drug interactions that could be a problem. Now, this is a paper from the New England Journal of Medicine just a couple years ago. The data went only to 2014, but it shows in the United States what the death rates, basically, from overdose due to prescription opioids and heroin in the United States, okay? Let's just go back to 18 years ago, right? The year 2000, the new millennium. Woohoo, right? Happy New Year. Things were, yeah, people died of opioid overdose and people died of heroin overdose, but like, look at what those values are, right? This is the number of deaths per 100,000 people in the population, right? Look at what's happened to both of those moving toward 2014. Both going up dramatically. Okay? Now, what's probably happened, I don't have the data on this, but what I'm kind of guessing is since 2014, what's happened is this one has probably started to go down, and that's because there are much more stringent federal regulations now about prescribing opioids. Doctors are more reluctant to prescribe opioids. Doctors know that they could get in big trouble if they overprescribe opioids, right? So this has probably gone down. I don't know for sure, but I'm guessing it probably has gone down a bit. Guess what's happened with this one, and I can tell you this for sure. It keeps going up, okay? And some of the reason that it goes up is because some of those people who used to be addicted to prescription opioids because they were overprescribed for years, and suddenly their doctor said, oh, I can't write you that prescription anymore, right? And what does the person turn to? Something they can buy on the street, right? And ironically, you could buy a bag of heroin for less money than a Percocet, right? If you're buying drugs on the street. Prescription drugs that are sold on the black market are much more expensive than much more dangerous street drugs like heroin and fentanyl. So the biopsychosocial model of pain is a better approach than opioids to dealing with patients that have chronic pain. It takes into account their social roles, their pain behaviors, and their way of processing and thinking about pain. So in other words, the biomedical model, we kind of stop here, right? Okay, it hurts, take a pill for it. It should go away, right? Biopsychosocial model starts to expand our thoughts about this and look at other things. This is another chart that looks at the interaction and overlap between the biological system, like, the actual tissue pathology, and any other comorbidities or concurrent diagnoses, central and peripheral sensitization, and substance use. Those are sort of occurring at a biological level, but then at the psychological level, fear, avoidance, anxiety, depression, etc. And then, of course, the social level, how that affects your relationships with your family, your job, etc. All right? So, well, what does all that mean? So how do we treat people then with chronic pain using this psychosocial model? Well, it means we've got to do things other than giving them pills. We've got to use physical therapies, right? Exercise, functional training, work reconditioning, reacclimation to functional activities, patient education, therapeutic modalities that we're going to be learning about with Dr. Conklin, manual therapy like massage or joint manipulation, dry needling, self-management programs, which is really a way of, again, patient education, teaching them how to take care of the pain themselves. What can they do at home other than taking a pill? Okay. Behavioral therapies like cognitive behavioral therapy, talking to a counselor, talking to a psychologist. And then finally, perhaps for some individuals, they want to explore things like acupuncture or other therapies, yoga, hypnosis, cannabis, which is now legal in the state of New Jersey for certain medical conditions, although still somewhat complicated to obtain when you want it and need it for chronic pain conditions, but thought to be helpful. Okay? What I will say about chronic pain is it's not easy to treat. It can be frustrating to treat patients with chronic pain, but the more you understand about it, the more patient you'll be, and the more you will really, perform a very careful examination, and then focus on using our modalities, our exercise, our manual therapy, etc. Brad.
Can you bill meditation to insurance? Like, can you build like a guided meditation?
Not as a physical therapist, okay, right? So if you are a practicing psychologist and it's part of your therapy session, you can put meditation into that, you can. But we don't have a billing code for meditation as a physical therapist. So. Has anybody ever been hypnotized? No one? Never, like in high school? Oh, you did? How did it work? Was it like an assembly in high school? Or?
Yeah, it was like a assembly of people to bring on stage.
Uh-huh.
And just like
Make them like bark like a dog or things like that, or crazy things?
You bark like a dog?
But like you went into like a trance and like secret moves, weird.
Yeah. Well, it is a real thing.
Yeah.
What hypnosis is essentially, it's facilitated meditation, and you're brought into a very, very deep state of relaxation or a trance-like state of mind. Okay? You could like watch the thing swinging back and forth, right? And then during that state of deep relaxation, suggestions are made by the hypnotist. For example, you feel less pain. You will no longer bite your nails. You will stop smoking. You will be less angry. So the hypnotist will plant these suggestions. And lots of times, those suggestions will then stick in your brain after you come out of the trance. So it can be effective. And the thing is, some people are more easily hypnotized than others, right? There are some people that they just drank way too much coffee and they're too high strung, and you're not going to be able to get them into that trance-like state of deep relaxation, right? Like me, on the other hand, give me like 30 seconds and I can be in a trance. It's very easy for me to sort of kind of go to that place where I'm feeling very, very relaxed. Okay. All right, so that's what we can do. So just to stress the importance of working with patients with chronic pain, communication is key. They've got to trust you. You've got to listen to them. You've got to develop a therapeutic relationship and focus on the fact that you might not be able to just make their pain go away, but you're going to help them manage their pain, and you're hopefully going to help them become more functional. All right? And I'll tell you one quick story about this that's from real life, and then we'll take a break. So I have a sister, and she's quite a bit older than I am. I guess she's about 18 years older than I am. And she is a real complainer, I'll tell you that. No matter what's going on, I'm going to hear about it for forever. But she had chronic neck pain and back pain. And she, the biomedical model was all she knew, was all she sort of appreciated, despite the fact that her brother is a physical therapist. Somehow she missed that. And so she goes to the doctor, her family doctor. What does her doctor start prescribing her? And keep prescribing her, I come to find out, for years, right? Opioid pain medication, Percocets, Valium. And she's like, and my pain's not getting any better, and I don't even get off this. And she's like, now she's not doing anything. I can't even go to the grocery store anymore. All I want to do is lay on the sofa all day. And she's taking more and more Valium, more and more Percocets, and she's becoming less and less functional. And I didn't really realize this was going on because we don't see each other that often or communicate on a very regular basis. And I guess she was also withholding this from me for a while. And I was like, okay, here's what's going to happen. We have to change what's going on with you, Carol, because if we don't, you could develop addiction, dependency. Your pain is clear. What these pills that your doctor is giving you, that are giving you, are obviously not making the pain go away. They're not helping. You're getting worse. Your function's declining and your pain is getting worse. So I finally talked her into going to see a physical therapist. And that physical therapist's name was Carol Cote in Hackettstown, New Jersey, who works with patients that have chronic pain all the time and does a lot of dry needling, which is a very exciting treatment advance in the management of chronic pain. And before long, I think my sister became addicted to dry needling. But I'd rather have her be addicted to dry needling than Percocets and Valiums. And she got back to walking over a mile every day for exercise, and she literally got her life back. And it took probably a good 3 months of going to therapy 3 times a week, but it was really an amazing turnaround. And I think it was just in the nick of time, because I really just think she was on the brink of starting to slip downhill so far that it would have been a much greater challenge. But Carol was an amazing physical therapist. She literally Carol was the therapist's name and my sister's name. They have the same name. Carol, the therapist, gave Carol, my sister, exercises, and my sister actually did them. It was amazing, right? And she just really started to feel better. Now, does she still have some chronic pain? Yes. Did her pain ever go away completely? No. Does she still complain and annoy me? Yes. But I don't care. She walks her dog a mile every day. She's happier. She's using minimal medications now, occasionally, for pain control. So it was a happy ending. But for a lot of patients, not such happy endings. Okay. On that note, we'll take a 10-minute break, and I'll see you in a little bit.
Do it. Yeah. No, I went to Wawa. It was started.
Yep.
Just like 30 seconds.
I'm excited to watch the movie. Is there three? Sorry. What? There are 2 or 3 I haven't seen it, but that was its own thing.
Now we're fighting EPT members, is fighting back, trying to get back in. It's a state by state.
Oh, it's like a one of them?
That's exactly all it is.
Or what's the order?
You're saying that physical therapists shouldn't be doing acupuncture. Us saying, but it's not acupuncture, it's dry needle. And there are some similarities.
Ooh.
We have a
I haven't seen Annabelle. Maybe we watch Annabelle and then.
to some extent the techniques, but also whereas acupuncture is not just Chinese medicine, there's acupuncture as part of that. So it's a huge and especially in an adult, and even more especially in an older adult with osteoporosis, it's very brittle and it's very stiff. It's going to shatter or break, kind of like ceramics would. Okay. Calcium homeostasis again. How do we get calcium? We have to eat it. Okay, it has to be in our food and in our diet. And then if we have too much, and our bone doesn't even need to store all of the excess that we have, we excrete it in our urine or our feces. Bone development is basically how our bones grow. So in fetuses, there is a sort of cartilage model of the skeleton. So in utero, a fetus doesn't really have bone. It has this little cartilaginous model of the skeleton. And somewhere in the middle, though, of each of those cartilaginous segments is known as a primary center of ossification. And from that primary center of ossification, there is interstitial growth, growth from within, where the cartilage will change into bone. That process is called endochondral ossification. It's a big chunky word, but it makes sense if you look at it. Endochondral, from within the cartilage, there is ossification that's going to happen. Okay? And again, it could happen either from within, from the middle, from the very middle of that cartilage model, that's interstitial, or on the outside surfaces, and that's called appositional growth, and that's from the cells on the surface. Because even the little the cartilaginous model of the skeleton has perichondria. It has a membrane around the outside. So this will start to develop in later stages of pregnancy and around childbirth. There's a lot of this going on. And then after delivery and in the growing years, this secondary center of ossification kind of takes over. And this is where our bones grow in length while children get bigger and taller because of the epiphyseal plates or associated with long bones. So remember that right here at the end of a long bone, at both ends, we have an epiphyseal plate. And in a growing child, that divides the epiphysis from the metaphysis. But it also results in growth of the bone. Okay? And at some point, usually around the age 18 or 19, those epiphyseal plates ossify, they themselves turn to bone, and that's why you stop growing. Okay? All right. Bone also grows in a growing child, not just from the epiphyseal plate. So here we see the epiphyseal plate. And when that forms new bone, it pushes toward the middle. So the epiphyseal plate causes bone to grow toward the center. So it would cause growth of the metaphysis and the diaphysis. Right? That's what the epiphyseal plate does. What about the epiphysis of the bone? How will that grow? That grows from the articular cartilage. the articular cartilage of a joint in a growing child is actually a source of growth of the very end of the bone, the epiphysis. Right? But then we get down to the epiphyseal plate, and the epiphyseal plate causes growth of the metaphysis and diaphysis from both ends. All right. Furthermore, though, you know if you think of a little kid compared to a big adult, not only have you gotten taller, right, but your bones have also gotten thicker and bigger, and that is from the appositional growth within the periosteum, right, the outer layer membrane around the bone. That causes bones to become thicker in diameter, right? So you kind of get from the periosteum the appositional growth to make bones wider, and from the articular cartilage make the epiphysis longer, from the growth plate, the metaphysis, and the diaphysis. Bone remodels over time. Wolff's Law, as mentioned yesterday, is an ongoing, slow, dynamic process throughout life. There are two sides of the remodeling coin, resorption and deposition. They are opposites. Resorption is taking bone away, right? Bone is eliminated, bone is removed. In people with advanced osteoporosis, they've lost a lot of bone. Their bone density is less, okay? And in old age, resorption tends to happen at a faster rate than deposition. Even bone is constantly metabolically active throughout your life, but as you get older, if resorption starts to happen more than deposition, that's how you can lead to bone density problems and osteoporosis. Deposition is when you have new bone, right, being formed over time, and that could either be good or bad. Now, good is when your bones get bigger and stronger during your growing years. They are getting more dense in certain areas. The trabeculae are orienting along of lines of stress so that your bones are not likely to fracture or what have you. A lot of the adaptive changes in bone due to external forces are good things, okay? But sometimes they're bad things. Bone spurs, osteophytes. Here is a heel spur that is grown off of the medial tubercle of the calcaneus, and it's growing in toward the plantar fascia in that direction. That shouldn't be there, right? That heel spur is a bony exostosis, or an osteophyte, an extra growth of bone. So in terms of language and terminology, bony exostosis is the same thing as a bone spur. And then the third word that's not here, you could write it in, is osteophyte. Right? They all mean the same thing, an osteophyte. Okay, we talked about Wolff's Law yesterday. This is just sort of a little schematic. You know, you can think of this as maybe woven bone over time, what's happening to it, or even a tendon or a ligament or some tissue that was very kind of, there was scar tissue, it wasn't getting adequate stress, the person just came out of their cast. This collagen's going all over the place. Over time, they start walking, they go to physical therapy, they start moving some weights again. The stresses that they are exposed to send signals to the tissue, and the architecture of the tissue starts to respond to that, generally in a good way, in this case, if we're looking at normal healing processes. And then the opposite of that would be disuse osteoporosis, where we go from having normal bone to osteoporosis and a loss of bone density. Now, what would you do, if you have an older adult with osteoporosis, what would you do therapeutically to help maybe increase or improve their bone density? What's a treatment? Brad?
Increase how much they walk.
Increase how much they walk. Dana?
Oh, I wasn't raising my hand.
Oh, you were just, okay, changing your arm. Okay.
Very light weight training.
Very light weight training. That's right. Resisted exercise and weight-bearing exercise. Why? because resisted exercise and weight-bearing exercise send the signal to a bone, hey, we have to respond to that force, let's become more dense. So you actually stimulate bone density with weight-bearing or weight-resisted exercises, resisted exercises. Now, Kyle, you specifically said something very important. You said light resistance. Why is that?
Because too much weight is going to put too much stress on the bone, and it's more.
Right. Remember, the bone is brittle and weak. If you do too much too fast, the bone might, you're not giving the time the bone to sort of respond, right? To maybe months and months of therapy, slowly progressed. If you do too much too fast, they could have a pathological fracture, right? Lifting too much weight or going running, instead of gently walking, you send your patient out with osteoporosis, okay, go running in bare feet on the concrete track. And then they come in, with like multiple fractures in their legs after one lap, okay? So weight-bearing exercises, resisted exercises, have got to be introduced gradually and slowly. All right, and again, Wolff's Law, we see in this frontal plane section that the trabeculae, if you sort of squint your eyes a little bit, you can see that there are some sort of lines or paths that they follow. And those have been informed by the stresses, body weight, ground reaction forces, muscle attachments, all those things. Okay, this is probably a great place to start because we can save this for next week. We'll be talking about cartilage next week. And then what we'll do next week in this class is we'll finish this lecture, and then we have a very short lecture on work-related musculoskeletal disorders. And I think it's a good time to call it a day. So thanks for your time and attention.